Well, welcome to Optometric Education Consultants National Webinar Series. Tonight we have a great topic and a great presenter, Identifying True Ocular Emergencies of the Posterior Pole by Dr. Carlo Polino. Dr. Polino is a graduate of the Pennsylvania College of Optometry. He completed a residency in ocular disease at the John F. Kennedy Memorial Hospital in Philadelphia. During his residency, his primary area of concentration was retina and neuro-ophthalmic disease. He also completed a retinal fellowship emphasizing medical and surgical treatments under the direction of vitreoretinal surgeons at Cilio-retinal Chester and Riddle Memorial Hospital in Philadelphia. Dr. Polino is currently a full-time assistant professor at Pennsylvania College of Optometry. He lectures in the retina and clinical medicine courses in both the traditional and the accelerated scholars program. He has also lectured other academic colleges within Salish University, which is the umbrella of Pennsylvania College of Optometry. He currently serves as the director of the Optometric Retina Service at the Eye Institute and the chief of the Chestnut Hill Primary Care Clinic. He's a fellow of the American Academy of Optometry, where he was the chair of the Retina Special Interest Group from 2018 to 2020. We'd like to now give a warm virtual welcome to Dr. Carlo Polino. And it is my great honor and privilege to sit here and listen to his talk. I find his talks to be well rehearsed, well prepared, and seasoned with clinical experience. So with that, please, Dr. Polino, take it away.
All right. Thank you, Joe. Greg, thank you, Vanessa. Thank you very much. So everyone, thanks for the invite as well. And as you can see, today's lectures identifying true ocular emergencies of the posterior pole. First of all, for COPE purposes, I have nothing to disclose at all. And as I think Joe and Greg had said, you can send your questions to me either during the lecture or after, whatever's easiest for you. I am going to finish on time. I'll follow COPE procedure, 50 minutes per hour, and I have 109 slides. So hopefully, like I said, it'll be a nice pace, and hopefully it'll be all clinically relevant for you. So my address, if you need me for anything, is right there, 830 Old York Road in Elkins Park. That's where I'm at right now at the school. My telephone number is there if you need me, and my email address is there as well. So feel free to get in touch with me, as needed. So what I wanted to go over with you first is when I was a student here, some of you may know the late Larry Gray, and at the time when he used to teach us neuroanatomy and neuro, let's say, optometry, he always had the 5A club. And so what I did over the years, I started to notice that there were more A's than Dr. Gray had originally given us. And luckily, all of these have A's in them. But tonight, we're going to look at some of them, not every one. We're going to look at optic nerve head swelling, the papilledema, even though that may not be the best choice of words from an optometric standpoint, but optic nerve swelling would be more correct. We're going to look at some other things here, giant cell arteritis tonight, central retinal artery occlusion, perforated globe. And I wish I had more time for all of these other ones, but we're going to focus on those that are of the posterior pole. And as any clinician needs to do, obviously, you have to determine, it's a no-brainer, do I have an ocular emergency or do I have an ocular urgency? And, here's the 10A club. These are the true emergencies for the most part. Proper triage is needed, and you'll see we'll get into this before the lecture starts. The meat and potatoes of the lecture. So even though I'm talking about true ocular emergencies of the posterior pole, when we look at causes of unexplained vision loss, sometimes it's retina that you can see there, and sometimes it's neuro. From a neuro standpoint, it could be functional visual loss. It could be ocular ischemic syndrome, where you have blockage of your carotid or your ophthalmic artery. You can have a certain optic neuropathy. We'll talk about that tonight. ischemic optic neuropathies, arteritic and non-arteritic. And you can have a stroke or a tumor that hurt your visual pathways. Those would be neuro causes of visual loss. Then you can have retinal causes, foveal ischemia. You can have macular edema from diabetes or from, let's say, cataract surgery. Macular hole, epiretinal membrane, central serous, degenerative myopia, choroidal neovascularization, and macular degeneration. So sometimes, obviously, it could come from both spectrums. So before we get started into some of these true emergencies, what is stressed here from Dr. Jeff Nyman, who runs our emergency clinic, and he stresses it very much so, the triage is so important, right? It's a process where we're trying to sort accordingly of what we're hearing. And it's to ensure that patients with conditions requiring urgent/emergent treatments are seen first. And you can see here chemical injuries, visual loss, let's say from an artery occlusion that we'll be talking about here shortly, trauma, pain, patient presents with pain, foreign objects. But whether the triage is over the phone or the triage is in person, it really should be you doing the triage and no one else. You don't want to have your front desk person get called at 8 a.m. saying, I lost my vision at 7:45 or 7:50, and then that front desk person says, oh, come and see Dr. So-and-so 9 hours later. That would not be appropriate. So you need to make that call, not the original call. You need to make the decision, is this an emergency? Is this an urgency? Am I going to see it? Is the ER going to see it? It's up to you to make that decision. It's up to you to use that cognitive skill. So that being said, you can see here, here's an example, right? It's basically, as you know, 80% of the diagnosis of any diagnosis comes from the history. But the interview, that triage is extremely important. Here's an example, temporal arteritis and ischemic optic neuropathy versus an artery occlusion. Those can't wait. Either you need to see it or you need to send it somewhere immediately. So that's where obviously this comes into play. So once again, you need to make the appropriate cognitive thought processes of what you're going to do. And tonight, obviously, emergencies occur from, you can see the sagittal view of this eyeball. Emergencies obviously come from the front to the back, anterior to posterior, but we're going to focus, as the title of the talk says, on the posterior pole, the retina, the posterior pole, the mid-periphery, the far periphery, including the optic nerve. So with that being said, let's look at this particular tissue first. And once again, I apologize, guys, but can you see my arrow okay? Can you see the arrow? Okay.
Yep, you're good, Carlo.
All right, thank you, guys. So this tissue, if you remember, Dr. Lombardi, if you went to PCO, what she always taught me is really true. The entire eyeball is set up for the retina's purpose, the entire eyeball. The choroid to feed it, its nourishment, the sclera to protect it, the vitreous to do both, the lens and the cornea to focus the light. The entire eyeball's purpose is for the retina's sake. And what I wanted to show you here on this particular slide, obviously here's the umbo. We know we're at the fovea. The sides of the umbo are called the clivus, so we know we're at the fovea. The central 1 to 2 degrees of vision. But what I want to show you is this tissue is so uniquely organized, and it was brilliantly designed. And if you look at these 10 layers of the retina, the first 9 layers are what we call the neurosensory retina. 10th layer is the RPE. Then you see the choroidal layers here, and then the protective scleral layer. But what I want to focus on right now, we know the retina has no color, and it's a transparent tissue. But I just wanted to set this lecture up because we're talking about the posterior pole. I want to set this lecture up that we just go over just a little bit of anatomy and physiology of this particular tissue that everything is trying to do for visual purposes, the sclera, the choroid, the vitreous, the lens, the cornea. So the first thing I wanted you to remember, obviously, that this is a transparent tissue, transparent. there are two blood retinal barriers. The inner blood retinal barrier is made by the tight junctions of the blood vessels that we see every day when we dilate. That's the inner blood retinal barrier. The outer blood retinal barrier are the tight junctions of the RPE, the 10th layer. You need two blood retinal barriers because the tissue has to remain clear. It has to remain transparent. The other key important fact here, everyone, the inner retina, so the nerve fiber layer, the ganglion cell layer, and the inner, let's say, plexiform layer, maybe a little bit of the inner nuclear layer, possibly, but these particular cell bodies that you see, these cell bodies have some mitochondria. But these cell bodies mainly, if you remember from college and you remember from high school, these cell bodies mainly function only on glycolysis. They're only going to make about 2 ATPs. The functioning cells down here, the cell bodies of this outer nuclear layer, where these are the cell bodies of the photoreceptors, they utilize, their mitochondria utilize glycolysis for 2 ATP, the Krebs cycle for 2 ATP, and oxidative phosphorylation for the other 34 ATP. So therefore, the outer retina utilizes sugar and other nutrients, carbohydrate and protein, to make a more efficient system for energy than the inner retina. And the reason for that, it's so well designed, everyone. It's so well designed. The inner retina cannot have a ton of mitochondria located in it because it has to remain as clear as possible. So that's why in diabetic retinopathy, hypertensive retinopathy, that's why these hemorrhages occur a lot easier, because you can't produce enough ATP to stay healthy. And so remember, that's one of the keys of this lecture. So let's give you one quick example before I leave this slide, everyone. In open angle glaucoma, you have an axon problem, the nerve fiber layer, axon problem. In angle closure glaucoma, you have a cell body problem. One is going to die a lot quicker than the other because the mitochondria are damaged rapidly. Angle closure, you damage the mitochondria. Open angle, you do damage the mitochondria, but over time. That's an example. An artery occlusion is an acute problem because you are damaging the inner retina and you're damaging the cell body, mainly the mitochondria. So these are just some topics here that I wanted to throw out to everybody. It's what we do daily, but I thought that this would set up the rest of the lecture to make things a little bit easier. So with that being said, I think that's enough about the anatomy and physiology. I then want to go into the next slide. And I want you to kind of remember this slide because it applies a lot, not only, mainly to retinal and neuro disease. It might apply to corneal disease as well. But if you ever listen to my longevity lecture, when we dilate someone, I always say to you, if you've ever heard me lecture, I don't care about finding a retinal hole or tear first. That's not first. Finding systemic disease is first. Then you worry about the hole and the tear. But when we talk about longevity, the retina can tell you longevity for the most part, about longevity, not of the retina itself, but of the individual, the patient. We always speak in the bottom here, the x-axis. We always speak in lifespan. Oh, I want to be 100. I want to be 90. I want to be 110. I want to be 115. We always talk about lifespan, but we very rarely talk about the other axis, the health span. And what is health span? It's their cognitive ability. If I'm going to live to be 95, I better keep my wits for me, right? Wits with me. I better have physical longevity. And I want to have, once again, good relationships with people, a sense of purpose. We don't want this to decline like this blue line. We want to keep, even though I'm talking about emergencies here, it's going to tie into this longevity. We want to keep this green line. You want to have a horizontal lifespan and you want to have a horizontal health span. So today, when I show you these cases of these emergencies, People who tend to die early, you see here, the goal for longevity is to reduce the chronic inflammation and when that disease process begins. Most people who, centenarians who live to be 100, they don't get disease processes until about the age of 90. Now today, when I show you all of these retinal diseases, you tell me if their curve is shifted to the right for longevity, or you tell me if the curve is shifted to the left. And that's one of the primary goals that we want to talk about. You can talk to this patient, have a very important conversation with them, not only about ocular morbidity and mortality, but about mortality and morbidity in general. So please keep this slide in mind when I show you these cases coming up. And as you all know, these are not from a book. These are from what we see here, what I see here on a regular basis. So let's look at the first true emergency. And that's what you see here in front of you, the central retinal artery occlusion. You see that you have the cherry red spot because that's the foveal avascular zone. That area is not supplied by the central retinal artery. That's supplied by the choroidal system. You see the area around the fovea is where the highest concentration of the ganglion cells are. That's why it's so white. But please pay close attention to these artery occlusions, everyone. I'm lucky enough that I've got the surgeon, I have the red free and the fluoresceins, so I'm going to try to compare with you here. But what I wanted to tell you is the retina, you see the mid-peripheral retina here, it will start to thin. The mid-peripheral retina, where the vortex veins are located, even though the vortex veins drain the choroid, they define the mid-peripheral retina. Look at it, it still stays red. It stays red because the retina thins to half of its size or thickness, and the choroid can actually start to feed it. So mainly the scotomas are within the central 30 degrees. So you're not always going to have this complete white appearance to the retina. You're not. It's mainly going to be up to the posterior pole. So you can see here that, look at the bottom here. In about 70% of patients, whenever there's a central retinal artery occlusion, there's hand motion or count fingers. The central scotoma is at about 30 degrees, roughly. The visual acuity improvement does occur. It usually occurs. A central retinal artery occlusion, you can get a few lines over time better. And then the site of the occlusion is usually at where the artery has punctured the nerve. So the point I'm trying to make to all of you is that these are not what I would say a complete white retina. They're not. It's mainly what you're seeing here. And we'll go into a little bit more of this as we look at some more cases. So what I wanted to show you here, obviously this is a true emergency, and artery occlusions are made into 4 categories, right? They're categorized. You see the non-arteritic, that means there's no giant cell. Then you have a transient non-arteritic. For some reason, the embolus passed through, or there was other reasons why they got the artery occlusion. Then you have the non-arteritic that has the cilio-retinal artery sparing. So you see those are there first. And then the big one, the other big one, that's another one on top of it, the arteritic central retinal artery occlusion with giant cell. So giant cell arteritis, you always have to think goes with CRAO. So please, when you leave here, you know, and these are kind of important, you'll see why later, but these are the 4 categories of artery occlusion. And we're going to look at every one of them before we leave here. CRAO is found in about 1 out of every 10,000 patients. And of these patients, 1 to 2% will get bilateral involvement. Central retinal artery occlusion, everyone. Look at this, back onto that lifespan, health span, X and Y axis. Life expectancy of patients with CRAO is at about 5.5 years compared to an age-matched normal of about 15.5. So once again, when you look at the lifespan versus health span, the graph is not to the right. The graph is shifted to the left, not what we want. Men are a little bit more affected than females with central retinal artery occlusion, and the mean age of presentation is at around 60, even though it can be much earlier. So those are some statistics. And once again, keep in mind lifespan, health span. All right, let's look at another central retinal artery occlusion. Once again, I don't mean to be making a huge point of this, but look, once again, as we approach the mid-peripheral retina, starts to go back to its original color because the retina is thinned and the choroid's taking over. You can see the same patient on the right. You see all of that loss of capillaries centrally. This patient must have been lasered prior for something superior temporally. But you can see that superiorly, there's a blood vessel not functioning well. And if you also look carefully, there's a small cilio-retinal artery functioning temporal to the optic nerve. Emboli is the most common cause. We all know that, either from the carotid or the heart, of CRAO, BRAO. Plaque from the carotid is the most common. So it's plaque from that carotid artery that breaks off, microembolism. And the aortic artery and the valve and the mitral valve are other possible areas concerning the heart. So in an artery occlusion, somebody's going to end up doing carotid Doppler and an echo of the heart. But you can see here, this patient is count fingers, no light perception, something like that. And we're going to get to what to do and so forth. So here, once again, is emergency number 1.
Hey, Carlo,
Yes.
while you just said count fingers, we had a question roll in.
Sure.
It says, if the foveola zone is supplied by the choroid, then why is the presenting, just like you said there, VA typically count fingers? Question mark, question mark, question mark.
Because it's a good question, mainly because of the fact that that ischemia is, remember in an artery occlusion, you start out with ischemia where the tissue is living. And then over time, you go into an infarcted state where you go from ischemia, like a vein occlusion, it tends to be living, to an infarcted state. And over time, even though the choroid might be feeding some of the blood there, the majority of those photoreceptors are gone. And not only the photoreceptors, but the ganglion cells, the mular cells, and so forth. So initially, I can answer that question. That's why the first 97 minutes, according to Dr. Hayray, the first 97 minutes of an artery occlusion, the VA is fine. The VA is totally fine because of that question, because that foveoid vascular zone is still not edematous for the most part, or starting to become edematous. It's not into a total, let's say, ischemic state yet, let alone an infarcted state. So in a roundabout way, that's why. Yeah, sorry.
Would it also be because the maculopapillary bundle that runs over to the optic nerve is also then compromised, and that's the kind of the signal too, right? To get to, so that's probably part of it also.
Yeah, the papillomacular bundle is compromised, but those are usually outside of that. They're part of that foveoid vascular zone, but that is correct. Those are all gone as well.
Okay.
Exactly right. Yeah.
Yeah, and I think part of it is you're having diffusion from the choroid up. That's not the best way to nourish that tissue. They need the perifoveal capillaries and oxygen diffusing through there. And that's why it's a light perception versus no light perception. Whereas those patients who have a cilio-retinal artery will be getting perfusion from 2 directions, and they have closer to normal visual acuity. But it's not unusual to have 2400 or worse in a frank CRAO.
So there, you'll see later also, as Joe just said, those ganglion cells and that radial peripapillary capillary network, like Joe had mentioned, it's hard to get that blood from that choroid up there, right? It's not that easy. You'll see, like he also mentioned, coming up, these other capillary networks that actually may come into play. So let's look now at the branch artery occlusion, all right? Now, I'll tell you why this somewhat is still an emergency to some extent, but this particular patient, once again, on both sides, you see here, what's interesting is the first question is, well, not question, but the first statement is you can see this very long fibroplatelet plaque, see some hemorrhages here. You see the branch artery occlusion pretty clearly. But what's interesting, like we had mentioned earlier, to some extent I mentioned it, these are really not retinal arteries. These are actually, according to Hay-Ray, arterioles. And so you can see here, their diameter near the optic nerve is about 100 microns. They do not have an internal elastic lamina nor a continuous muscular coat. And why that's important, if you look at Hay-Ray's work, and I'll go back and forth with this, why that's somewhat important is that Hay-Ray will tell you that a giant cell arteritis patient will never get a BRAO. They won't. Because giant cell arteritis affects medium and large arteries. These are actually arterioles. And I'll make another statement coming up, but later. But you can see there are there's an embolus here, there's an embolus here, there's a large one here, there's multiple ones throughout. But this is a branch retinal artery occlusion. Here's another branch retinal artery occlusion. 3 emboli. The other eye, there's an embolus stuck here. So this is the opposite eye, branch artery occlusion. And then once again, you see all of these individuals, right? Multiple large plaques, fibroplatelet plaques, multiple plaques all over. The curve is not shifted to the right the way we want it to, it's shifted to the left. So I'll tell you why I'm putting branch artery occlusion, and to some extent, I'll tell you why I'm putting it into the urgency/emergency category coming up. Now, let's take a look at this particular patient. Okay, now initially you see this patient presented with a branch artery occlusion. All of the surgeon that we sent it to, the ophthalmologist, the retinologist, everything was followed appropriately. And then within a short period of time, within 4 months of this presentation, emboli were thrown again, and the patient now has a central retinal artery occlusion. So branch can occur first. You can actually see some edema here, everyone. And then a branch artery occlusion can become a central retinal artery occlusion. So that's why close monitoring and a very good workup systemically is important, and close following with internal medicine, whoever else. So I think this is what was mentioned before. If you look carefully, let's look at this. You can see my arrow. What Hay-Ray believes, Dr. Hay-Ray, who did most of the studies, what he believes is that you see where the artery punctures the nerve. This is where most embolic artery occlusions occur, about 10 millimeters back from the lamina cribrosa. If it is a thrombus, he believes that usually that the thrombus will occur at the lamina. Most of the artery occlusions are embolic, not thrombotic. So that's an interesting point. And then the other thing, I think someone mentioned it earlier, Joe might have, is you have another system. You have the short, or you have the posterior ciliary artery system that comes in that gives you the cilio-retinal artery, that you got a dual blood supply, right? So you've got this opportunity here for dual blood supply, and you see the patient on the left, everyone. Here's a central retinal artery occlusion with a cilio-retinal artery sparing, and they might have a little better visual acuity. So I just wanted to show you once again, let's just reiterate, back here, 10 millimeters back is where the embolic nature occurs. If it's a thrombosis or blood clot, it's usually up near the lamina, according to Dr. Hay-Ray, who did the majority of the studies. And then once again, the ciliary system gives you this type of cilio-retinal artery supply as well. It could be small or it could be large. Now, here's the interesting part that we have to remember. When this patient came in, remember what I said before. What Hay-Ray says is there's no such thing. If you have giant cell, you cannot have a branch retinal artery occlusion. It has to be a cilio-retinal artery occlusion. It has to be. So look carefully here. You see, this appears to be a cilio-retinal artery occlusion right here, and the nerve is a little swollen. You see some hemorrhages. They might have the metabolic syndrome. You see some hemorrhages. Cilio-retinal artery occlusion. Now, look what happens about a week later. Same artery occlusion, but more swelling, more blood. And what happens here is what this person was worked up for is giant cell arteritis. And that was the main thing that they were worried about, and because of the steroids we'll be talking about coming up. So what I want you to think about here is, do I have a CRAO? Do I have a BRAO? Do I have a cilio-retinal artery occlusion, right? And that's what we've kind of neutralized down, or let's say narrowed down to this point. This is where we've kind of made these conclusions of what do I have in front of me. Now, the other thing is this. If you scan the literature as well, a lot of what Hayray actually goes after, even though Hayray is an MD ophthalmologist himself, what he tends to battle most ophthalmologists is that most ophthalmologists think you cannot get collateral vessels after a CRAO, and you can. A lot of times, if you read his literature, these eyes are PRP'd when they're not actually neo. Right? Hayray's, when you read the majority of Hayray's articles, Hayray will say, how can a dead tissue secrete vascular endothelial growth factor? And if a dead tissue, an infarcted tissue, these are not new blood vessels. These are collateral blood vessels. So I just wanted to put up here, we tend to think collateral vessels after vein occlusion, but that's not 100% true. Collateral vessels do occur. Collateralization does occur after CRAO. And according to Hayray, once again, a lot of unneeded PRP is done. So because it's thought of as neovascularization, and it's not. So what you see here, this presentation, even though what we said earlier, 97 minutes before you start to get some problems with that functionality of the retina. After 4 hours, it's pretty much gone, the functionality. And you see narrowed retinal arterioles, the cherry red spot. You might have the cilio-retinal artery functioning well. You're going to get a relative afferent pupillary defect, and over some period of time, you're going to get pallor. And that etiology, take a look at this. We've said earlier, I said earlier, emboli is the number one, whether it's cholesterol, fibroplatelet, or calcific. As you know, calcific is mainly the heart. It could be a blood clot. We look at giant cell. Once again, giant cell is an etiology of artery occlusion. When you have that artery occlusion, you have to ask those questions of giant cell arteritis. We'll get to that. That's the second emergency. Could it be a blood clotting problem? Could it be sickle cell, migraine, optic nerve head drusen? Look at the bottom one. AFib has been known to cause artery occlusion. Hyperhomocysteine, valve problems, mitral valve, patent foramen ovalis, birth control pills, and so forth. So you got a lot of etiologies there. So I just wanted to go over that with you. The treatment, multiple ways to look at this. I'll tell you a quick story, what some of our surgeons do here, what I see them do. They want the ocular massage done, possible high dose aspirin, possibly. I wish we had more time for this, but we don't. Lower the IOP if you can. And then take a look at the TPA and things like that. TPA and sublingual nitroglycerin, even though that's out there, Hayray feels that it only works in 15% of the cases. It's very difficult to get to the blockage site. So it doesn't really feel that that's necessary. But we have one of our surgeons, everyone, and maybe you've seen this before, when they're doing the digital ocular massage, obviously they're not pushing too hard where the patient faints. But one surgeon, some of the surgeons do it in the chair, sitting up, and some do it on the floor. They put the patient's back on the floor, their feet up in the chair to try to do the ocular massage, and it's got a name to it, Tremblenberg position or something of that nature. They want as much blood flow, I guess gravity pushing the embolus through if possible. So I see it done both ways. So anyhow, treatment is what you see here. Now, this is where the controversy arises. If you look at the literature in a Will's Eye manual, or you look at some of the other literature, obviously Hayray would say this isn't true. you're not going to get neovascularization because an infarcted retina can't secrete VEGF. He does say that neovascularization can occur if the patient already had diabetes, if the patient has occlusive artery disease of the carotid, ocular ischemic syndrome, but still, this is the recommended follow-up. 1 month, 3 months, look for any iris neo, look for any optic nerve neo, and so forth. And then you'll see some of these other things for this workup. And once again, I apologize, I wish I had more time. Now, I went over the artery occlusions, central, branch, cilio-retinal. What about if you just have emboli? So you can see here, there's an embolus here with no major sequelae, let's say. A few months later, it's gone. Here's the other eye of that same patient. Initially, you have these, let's see, it could be an artery occlusion, large cotton wool spots, but you have these emboli or the embolas stuck here. Eventually, they leave. You can see NFL dropout down here very clearly. All right, so the fourth thing is, what about emboli without any problems? Or let's say emboli that you see visibly with or without an occlusion. All of that is lumped together. So let's look at now the systemic testing that either you will do or somebody else will do. Obviously, if the patient is older than 50, 55, get the general workup for giant cell. Going to get the evaluation CTA, the intracranial vessels, carotid Doppler, and so forth. Blood pressure, lipid profile, blood sugar, CBC with platelets, possible coagulation. Look at the echo. Remember the heart. Look at the heart. Mitral valve. The aortic valve can throw emboli. Both valves at the same time. That's pretty high in the statistical analysis. A patent or patent foramen ovale, a hole that didn't close properly, or a tumor of the left atrium, a myxoma. All of those are done. And what they found, Hayray Fields and some of the others, I guess, transesophageal echo is better than a transthoracic echo. And look at the bottom one. We know recently that the bottom one here, possibly the DWI, the diffusion weighted imaging MRI, has to be done within 24 to 48 hours. And that is anyone with the CRAO, BRAO, cilio-retinal artery occlusion, emboli with or without symptoms. And DWI, here it is. This was a real big topic at one of the academy meetings not too long ago. And what happens here is there's a big debate here at the Eye Institute. We have about 50 doctors. Some doctors, they do the massage and they get them right to the stroke center. And then there's a debate, how come you didn't go to the retinologist and so forth? That's for another day. But there is a debate here about that. 1/4 of patients with acute retinal ischemia, even if it's transient, already have had a stroke if it's looked at with a DWI MRI. 10 to 15% of patients will have a disabling stroke within 3 months after that TIA. Half of that occurring within 48 hours after resolution of the TIA. So, guys, all I want to tell you here is that this is, obviously, you all know this. It's been out there for a while. Somebody has to get that patient for a DWI. Now, this is not me speaking here, but this is what is stressed to us here. From neuro-ophthalmology to neuro-optometry, this is what is stressed to us. You do whatever you want. I'm only telling you what is given to me. Do not send these patients with CRAO, BRAO, cilio-retinal artery to their PCP, cardiologist, neurologist, neuro-ophthalmologist, or retina specialist. There's where some of the debate is. Do not try to obtain a workup yourself. I'm not saying you're right or wrong if you do. I'm only once again telling you what we do here and what is stressed here. They want the patient sent to the emergency department that has any emergency department, but one that at least has an acute stroke care center. That's what's stressed. So once again, I apologize. We can't talk about it much, but I just wanted you to kind of have this and then you make your own decision. Okay, I told you there's some debate here. Now, I just
Yeah,
sent this
Carla,
into-
I'm just going to echo that. And Joe's the one that kind of should get the credit for this in a sense. You know, out of Emory is Nancy Newman and Valerie Buis, and two huge neuro-ophthalmologists that have, there's lots of papers on PubMed if the audience wants to go out and read about it. But I can tell you, it's been one of the easiest things that I've done in my practice when someone comes in with I just had one the other day, a TIA, and we sent it right over to the, you know, it was classic. She's like, hey, look, when I do this, you know, it literally goes out and maybe returns in 30 seconds, you know, maybe to a minute. You know, CRAOs, BRAOs. Luckily, I got a stroke ready hospital. You just call them up, tell them, hey, I got a patient coming over. They have a stroke in their eye. So
Yeah.
I know it's controversial, but I think you're going to see that shift because it's getting a lot easier out there.
Yeah, and I agree with you, Greg. I think you're right. I think the shift has already started to occur. Yeah, that's exactly right.
And interestingly, the American Heart Association is coming out with a new paradigm that says CRAO is a stroke. They're not saying an ocular stroke. They're listing it as a stroke.
And one last clarification for the audience listening, that does not apply to a venous occlusive disease. That is arterial occlusive disease.
That is correct. Yep.
There is some questions in the chat room. It is send to acute stroke center if acute CRAO and or BRAO or just acute CRAO.
Well, it would be all of them.
Yes.
All of them.
And TIA, which used to be known as amaurosis regax as well.
That would go as well.
So if there's an embolism, but there's no CRAO or BRBO, do you send to a stroke center?
That's where some of the controversy exists. And that is, I would say, error on the side of caution. And me personally, I would be on the phone with somebody and then myself, their primary, someone at the ER to see what was best to do, but doesn't hurt. Okay, so let's just keep moving here. Let's look once again, embolism, cardiac disease from arrhythmias, valvular disease, endocarditis, ischemic lesions, tumors, and carotid disease. So once again, they're going to be looked at equally. And once again, that's what Joe and Greg had just said here, stroke and the central retinal artery occlusion. It is a stroke. And the risk factors for CRAO are the same atherosclerotic risk factors for stroke and heart disease, right? And you see here, individuals with CRAO may be at risk for ischemic end organ damage, such as a cerebral stroke. It's to restore vision if they can, but at the same time, manage those risk factors that may lead to other vascular conditions. So, I think that as we are just mentioning here, that DWI is important, and time is of the essence. So we just got to make sure that's the end of emergency number one. We just have to make sure that we understand it, how to categorize it, and like we just said, there might be some controversy. Just do the best for the patient. It's as simple as that.
And Carla, we can wrap up with this last comment here from Mary, who's in the chat box here. It said, I had a patient with a branch retinal artery occlusion, sent them to the retina, and they tried to send her to the hospital, right? So that's what, again, now Mary out there in the audience listening, that's what Carla was saying a few slides. Retina doesn't want to see them, PCPs, neuro, send them directly to the hospital. You don't have to send it to retina, but that's why we take CE. And I'll continue what she says here is for a stroke. And she got mad at them because she recently seen her heart doctor and said nothing about that. She went to her heart doctor instead. So yeah, I mean, the studies are out there. Mary and Carlo and Joe can support that, is that, when they have these BRAOs within the first, I think whatever it is, 48 hours, 80% will have a stroke or a heart attack. And that's the best place for them to be, is in the hospital in case that happens, to have the proper care. So,
and I just wanted just to say it again, where some of the controversy is here at this eye institute is, do you go right to the DWI, or do you go to the retinologist and then the retinologist sends it? That's part of the controversy. So Greg has already mentioned that and so forth. So yeah, it's interesting, but it's good that we're talking about it and you're aware of it, and then you make the call that you feel is best for the patient. All right, let's go to the next emergency. The next one here is what's called an arteritic anterior ischemic optic neuropathy. So the AION, the AAION. And as you can see, everyone, it is a, look what I wrote up here. We all know this. It is a pale swelling of the optic nerve, pale. The non-arteritic anterior ischemic optic neuropathy tends to give you what's called luxury perfusion. But that when you have that pale swelling, you have to think giant cell arteritis, pale swelling. Now let's look at this. It's an occlusion. The immune system is attacking. It's an occlusion of the short posterior ciliary arteries. It's an acute, usually painless loss of vision. Hay-Ray's statistics again show count fingers to no light perception in about 65% of the patients with AAION. You got that pale swelling again with some other hemorrhages that can occur. Now look at this. We always say syphilis is the mimicker, but really giant cell arteritis is the mimicker. It can give you AAION, arteritic anterior ischemic optic neuropathy. It can give you a swollen optic nerve that's pale. Look what else it gives you. We already talked about it. One of the 4 categories, CRAO, arteritic CRAO. And look what else presents, cranial nerve palsies. Cranial nerve palsies. So one other thing, cotton wool spots alone may be the only presentation. If you look back, look at this, cotton wool spot, right? So this is the next one, number 2, arteritic anterior ischemic optic neuropathy. And remember, it goes after medium, the disease goes after medium and large arteries. So it will go after the central retinal artery. It will go after the posterior ciliary system. It does not go after the small branch arterioles. That's why Hay-Ray once again says if you have a BRAO, it is not giant cell. You can look into that research in that literature. So arteritic anterior ischemic optic neuropathy has to be differentiated. It's always arteritic versus non-arteritic, and it's always arteritic until proven otherwise. Males less than females. One study showed 70% of the people who get arteritic from giant cell were females, 30% were males. Look at the top one. Amaurosis fugax is usually a presenting sign, amaurosis fugax. And the patient is usually greater than 50 to 60 years of age that have arteritic. Now, here's what's interesting. Do you see these presentations? The headache that's unique, the scalp tenderness, the jaw claudication, the weight loss, the fever, the polymyalgia rheumatica, maybe mild depression. If you do a good history, the eye may be totally fine. The eye may be totally fine. 20/20 vision, extraocular muscles are fine, no cotton wool spots, no swollen optic nerve. But enough of these symptoms, you have giant cell until proven otherwise. And so you have to think this person probably needs to go immediately as well to the ER. And what are some of the labs that can be done? The SED rate will be elevated in most cases. The C-reactive protein will be elevated. Platelets, thrombocytosis will be elevated. Platelets, the higher the platelets, that'll tell you a lot. It's usually it's a tough prognosis when you have thrombocytosis. And then the CBC will differentiate anemia of chronic inflammation. It'll show you that. So here's some of the lab work. And then I just wanted to give you some statistics of giant cell AAION, usually about 10 to 30 cases per 100,000, usually older than 50. Scandinavian and Northern European descent. It's an inflammatory disease. I keep saying it goes after middle and large sized arteries. And look at the headache. The headache is a unique headache, no distinctive characteristics. And it's usually this type of new headache, usually parietal temporal, sometimes occipital, greater than 50. And the pain, there's pain from obviously claudication of the facial artery, claudication of the superficial temporal artery, but you can get scalp pain, face pain, oral mucosa pain, jaw claudication. All of these things, giant cell arteritis. And I just said this already. I've said it multiple times. White blood cells going after medium and large arteries. And take a look at this. Here is the definition of polymyalgia rheumatica, the cousin possibly of giant cell. Stiffness in the neck, shoulders, and hips. 50% of giant cell patients have polymyalgia rheumatica. And is there this link, right? And there's an increased risk of stroke and reoccurrence of GCA. So we've got to be concerned. Is this going to attack their heart? Is it going to attack the brain? Is it going to attack their kidney? Is it going to attack their liver? And so forth. And you can see here it is, that pale swelling. But look at some of these interesting statistics. You can have a normal ESR. You can have a normal erythrocyte sedimentation rate. Normal in about 13% of GCA patients. And 20% of GCA patients don't have any of those symptoms that I mentioned here. So 20% of patients don't have the headache, the scalp tenderness, the jaw claudication, the night sweats, and so, the fever, they don't. So just keep all of that in mind. But obviously, if you see this particular patient there, that's going to give it away with a swollen optic nerve that's pale. And I just wanted to show you, please look at the bottom left of the slide. The bottom left of the slide is important. What other arteries does it go after, this disease? It will go after the superficial temporal artery. It'll go after the heart, the coronary system, the subclavian, and the facial. That's why you have jaw claudication and some of these other symptoms. So please keep that in mind, medium and large sized arteries. Okay, now watch this here. Look at the difference. I'm going to show you some other patients who've come in. Look at the difference of this unilateral swelling. You can see it's not the pale swelling of giant cell, of the arteritic anterior ischemic optic neuropathy. Look, this one is very easily seen. It's more of a luxury perfusion, a hyperemic swelling. This is cat scratch disease, Bartonella henselae. The domestic cat is the primary host and the cat flea is the transmitting vector. This person was on Cipro 500 and Doxy 100 as the treatment. But you see a swollen optic nerve that is not pale. Still have to rule out giant cell depending on the age and so forth. This person happened to be 30. This one is last week. This man came in 20/20 vision. I'm here for a routine exam. Oh, by the way, I just saw my primary. I have an elevated white blood cell count. They might think I have leukemia. Upon dilation, you see the swollen optic nerve, superior temporally, the striated hemorrhages off of the optic nerve. I ended up calling neuro at Wills, and they said to me, Carlo, bring them right down because it could be infiltrative. As you can see here, infiltrative, he might have leukemia, obviously, infiltrative leukemic optic neuropathy versus AAION. He did have hypertension, he did have diabetes, he had the metabolic syndrome, but they wanted this, they were going to get a biopsy anyhow of his bone marrow, so they wanted to hurry it up. So you see, it's not a swollen optic nerve, it's not. Here's another one. This one is a non-arteritic ischemic optic neuropathy, non-arteritic. Swollen optic nerve, sectorial, but you get the point. But what I'm just trying to tell you is that it's always arteritic anterior ischemic optic neuropathy until proven otherwise, but the arteritic at least gives you some other clues. But I just wanted to show you some differentials. What about the biopsy, the superficial, the biopsy of the temporal artery? Possibly can be done within a week. If they're going to start steroids, it can be done within a week of starting the steroid. The specimen could be up to about 2.5 centimeters long. If the biopsy is negative, but suspicion is still high, they'll biopsy the other side of the head. And in 13% of cases, it will be positive on the opposite side. So that's some interesting facts there, everyone. And here is something else that's interesting, somewhat current. Look at the signs and symptoms. 1, 2, 3, 4, 5. evidence of a new set of ischemia or new onset of ischemia, like a CRAO, AAION, new headache, abnormal laboratory findings, jaw claudication, and superficial temporal artery findings. If one or no clinical findings, there's a possibility they'll look at other causes if there's one or no clinical findings. Two findings, start oral pred and plan for the temporal artery biopsy. Okay. Three or more clinical findings, start oral pred or high-dose IV methylprednisolone and plan for the temporal artery findings. This is somewhat interesting. And then, as you know, everyone, they could be on an oral steroid the rest of their life. If they can't tolerate that, they might go on methotrexate and obviously always suspect reoccurrence or the other eye going to be attacked. So that's AION, that's number 2. And then look at this rule here. It's kind of interesting. If a person has giant cell arteritis and their optic nerve is affected, 1/3 of optic nerves in the fellow eye will become infarcted within 48 hours if untreated. 1/3 of optic nerves in the fellow eye will become infarcted within 1 month. And 1/3, the second eye is very rare after the 1 month period. So it's just this, they call it the AAION rule. Just something to think about. 48 hours, and then 1 month, and then you're clear for the most part. 1/3 are cleared after that. All right, let's now go to number 3. Number 3 is emergency is malignant hypertension. So this man walked into clinic as a routine exam, stating, I can't see very well, my vision is blurry. He's a 60-some-year-old Caucasian male. And what I wanted to show you here, you see he has grade 4 malignant hypertension or grade 4 stage ocular findings. And you see here immediate attention of chest pain, cognitive impairment, blood in the urine, sensory or motor defects. But look at malignant hypertension. You're probably going to start to go to stage 4 when the blood pressure is 180/120 or more. It could be 115 as a diastolic or so forth. But look at the swollen optic nerve. Look at the exudate. Look at the striated hemorrhages, the macular edema. So this is malignant hypertension. Let's look at a few others. This is your definition of hypertension. You all know this. When you get into the hypertensive crisis, there's the 180/20. Whenever you start this emergency, you have the crisis plus an end organ damage. Bingo. You see that there. So you got the crisis, 180/120, 180/120, and then the end organ damage. So malignant hypertension is a true emergency. Essential hypertension in the United States is about 95% of cases. When we see this malignant hypertension, there's a good chance it's going to come from here. Secondary hypertension, sleep apnea, medications like steroids and birth control pills. Look at this one, hyperthyroidism. Look at the big one, pheochromocytoma, a tumor of the adrenal glands, right? Fear of impending doom, right? Norepinephrine secreted, epinephrine. Another big one, the renal artery is blocked, renal artery stenosis. And then obviously illicit drugs. All of those cause malignant hypertension. And this is what I just said here. Usually the optic nerve will start to swell somewhere at about 115/120 diastolically. Urgency, this is terminology, urgency, hypertensive urgency without retinopathy or central nervous system changes. Emergency with retinopathy or central nervous changes. So just some terminology there. We've already gone through this to an extent. When you get to grade 4, you have the narrowed arterioles because of autoregulation. You've got the edema, the striated hemorrhages, the cotton wool spots. And when you get to grade 4, you've got this optic nerve swelling. And look to the right, severe cardiac, renal, and brain dysfunction. And I'll get into that coming up. And this is basically what every optometrist needs to know right here. Remember the retina. The retinal blood vessels are under autoregulation. The choroidal blood vessels are under the sympathetic control. They're under the autonomic nervous system, but not the retinal blood vessels. The retinal blood vessels can auto-regulate. You need more blood, they dilate. You got too much blood coming in, they constrict. Well, if you got this high blood pressure, they're going to constrict, and that's why you have a reduced AV ratio in grade 1 and grade 2. Eventually, you can't auto-regulate anymore. You can't constrict anymore. They're going to start to bust. The capillaries will burst. You get the cotton wool spots, the hemorrhages, and the exudate, and then look, the swelling of the optic nerve. So it'll kind of tell you what the diastolic blood pressure has recently been running by what stage of hypertensive retinopathy you have. And I'll show you a few of ours. This person here, you see the optic nerves are not swollen. You see that they have hypertensive retinopathy, the striated hemorrhages, the cotton wool spots. You know that they're running somewhere about 110, 105, maybe higher over the last few months. Autoregulation is disrupted. They're not yet into grade 4. Okay, now let's look at a few more of our grade 4s from here. Look at this one. Look at the lutein and the zeaxanthine. Look how much edema you have here. It's so prominent, the xanthophyll pigments, because it's all elevated. The nerve is swollen. You know, it's interesting. The optic nerve will swell in these cases like the isn't rule in glaucoma. It swells inferior, then superior, then nasal, then temporal. Look at the nerve fiber layer dropout. The eye is dying. Look at the NFL dropout here. It's not good. Here's another one. These are two separate patients. This is a patient on the right with malignant hypertension. There's a patient on the left. The man on the left, I got to tell you this story real quick. The man on the left is 39 years old. He's 20/20 vision. And he came in, he's 20/20 at distance. He came in because he needed readers. But both optic nerves look like this. And so his blood pressure was malignant. I said, sir, you have to go to the emergency room. He wasn't too happy. And he went to the emergency room. And then what happened was they let him go. Then they lowered his blood pressure, let's say after a few days. I think they admitted him and lowered the blood pressure. Then what happened was the ER doctor, the neuro found out, and boy, neuro was not happy. Neuro-ophthalmology was not happy because he was not scanned, because they said to me, look, there's no exudate. People are entitled to more than one disease. This could be pseudotumor cerebri, tumor cerebri, meningitis. And he went back in for his scans and his lumbar puncture and MRV and everything. So sometimes they're going to do more than others. Here's another man, malignant hypertension. The nerve is not as swollen as these individuals that you see here, but they're still swollen. This is grade 4 malignant hypertension. And then look at this. We just did hypertensive retinopathy. We did hypertensive optic neuropathy. Now look at hypertensive choroidopathy. Forgive me, these are some, that's what I mean by that is, these are artifacts, but this is a 20-year-old who had eclampsia, and they delivered the baby. The patient, she's 20 years old. She has eclampsia. She says, I can't see very well. The very next day after discharge, she comes into emergency, and you can see she's so young. You see all the retinal sheen, but look at the choroid. It's all stroked out. It's all stroked out. And this is hypertensive choroidopathy. And you'll probably never see this. Maybe you will. Look at the congenital retinal macrovessel going right through. This is very rare. You know, she comes in with a rare congenital finding plus hypertensive choroidopathy. And luckily for her, there is some hypertensive retinopathy. Luckily for her, she didn't lose any vision. But here's another hypertensive choroidopathy. If it lingers too long, the choroid strokes out and the RPE can't be nourished properly, and you get this hyperpigmented spots and streaks known as Ischemic spots and Sigris streaks. Okay, and what they thought happened here was, you see this little pallor here in the optic nerve? Neuro-ophthalmology felt, neuro-optometry felt that they lowered the blood pressure too fast in the emergency room. They kind of stroked out her optic nerve. But Ischemic spots and Sigris streaks are hypertensive choroidopathy from malignant hypertension. Here's another one. This is from a colleague of mine at SUNY, Tim Poirier. She gave me this, but this is her most recent one, I think, possibly. You see the Siger streaks in the L-shaped spots. So hypertensive choroidopathy. And then don't forget this. If a person tends to have a weakened blood vessel, a congenital weakened blood vessel, sometimes it can balloon out and you can see them. They're called RAMs, retinal arterial macroaneurysm. Well, sometimes you can see this, the grade 3 hypertensive retinopathy. Sometimes they can burst and they can give you all of this hemorrhaging. It's usually pre-retinal, sometimes vitreal. So a RAM can be exploded, let's say, from elevated BP, all part of malignant hypertension, or even you can see here grade 3 hypertensive retinopathy. So causes, once again, I already went through them. I just want to say one more time. Usually it could either be essential hypertension or it could be secondary hypertension. But a lot of the secondary hypertension that you saw here, all of these are usually ruled out. And we've already gone over them. The renal artery stenosis is a big one. Make sure there's no pheochromocytoma. They'll look at that adrenal gland above the kidney. They'll make sure there's no scleroderma and pulmonary hypertension. Look at the next to the last one. The aorta is like kinked, coarctation of the aorta. They're looking at all of this. We talked about preeclampsia, eclampsia, and then illicit drug abuse. All secondary hypertension, malignant hypertension. And everyone, I put this in here just because you don't have to have malignant hypertension. Any of you or your family members, your patients, your friends, look what hypertension in general does. Hypertension goes after the basal ganglia. Basal ganglia are huge for EOMs, saccades, just any movement, the basal ganglia. Look what it goes after. 60% will go after basal ganglia. The thalamus, the visual pathway is the thalamus, the pons, and the cerebellum. And this is what I want to show you. Any of you that have hypertension, look at this carefully. I'm going to show you this. We stress this here big time. Here are the 5 basal ganglia. Here is, this one here is the caudate. It's interesting that they're called basal ganglia, everyone. They shouldn't be called basal ganglia. They should be called basal nuclei. Ganglia in the peripheral nervous system. I don't know why they call it that. But look, here's the caudate. And caudate is a big basal ganglia. You see it here. And if you've ever heard of the term Huntington's chorea, that is the caudate that's messed up. Then look at this one. This one here. This is putamen. This is Wilson's disease. You've heard of Wilson's disease with copper. And then look at the globus pallidus, this one and this one. Anytime we make a movement, see my arm moving, anytime I do EOMs, pupils, the brain, the cortex is going to send to the basal ganglia to refine the movement and make sure it's necessary and refined. Look at the other 2. The subthalamic nucleus is here. That's down here. And then we all know about dopamine in the midbrain, substantia nigra. Too much dopamine, right? Schizophrenia. Not enough dopamine, Parkinson's disease. These are the 5 basal ganglia: caudate, putamen, globus pallidus interna, externa, subthalamic nucleus, and substantia nigra. Hypertension goes after all of them, essential or malignant. And I want to show you one other big structure here. This is the corpus callosum, connecting one side of the cerebral hemisphere with the other. But look at this. This is a very big structure right here. And on the other side of the brain, that is known as the internal capsule. If the internal capsule has a major stroke, a patient is a hemiplegic, whether it's essential hypertension or it is malignant hypertension. And here it is again, in a little better view. This is the internal capsule. And if you remember from your anatomy, the internal capsule is supplied by what's called the striate arteries. And they are somewhat fragile, somewhat. And that's why when they say 120 over 80, 125 over 85, no more than 140 over 90, there's a reason for that. And that's why the basal ganglia are hit hard and the internal capsule from hypertension. Okay, so if someone does have malignant hypertension, they're going to go see probably the emergency room for a slow lowering of the blood pressure. They may be admitted for 24 to 48 hours. depending on how high the blood pressure is. And we've already mentioned hypertensive urgency versus hypertensive emergency. And then you see this here, that you don't have to follow this, you don't. This is somewhat our protocol here. If the person has malignant hypertension, and I say to them, hey, what day is it? And they say, this is July the 30th, when it's not. Or what's your last name? Hypertensive encephalopathy, and they give the wrong last name or whatever. Hypertensive encephalopathy. If they have chest pains or palpitations, they have hypertensive renal, they have blood in their urine that morning, whatever. They have motor weakness, sensor weakness. I'm not putting them in a car to go drive to the hospital. They're going to get, someone's going to take them, or 911. But we ask these questions and put them in the chart, obviously. And then the vasodilators are given in the ER. Look at this patient here. It's amazing. Look at the NFL dropout already. Dropout, dropout, dropout. Large cotton wool spots, right? And the vasodilators are usually, these are the 5 major vasodilators given in the ER. All right, to try to bring that blood pressure down slow. And then if it can't be, look at all the things that can happen. The aorta can dissect, coma, edema of the lungs, heart attack, heart failure, stroke, and sudden kidney failure, all from the malignant hypertension. All right, so that was number 3. Let's get to number 4. And
Carlo,
yes.
Carlo, before you jump way back in giant cell arteritis,
Yeah.
Dr. Shovlin had a question regarding Actemra being used. Do you have any experience? Dr. Saka replied to the chat that, you know, that's used. It's a biologic in conjunction with giant cell arteritis to decrease the steroid load and to stop decreasing the steroid load in time and amount, and then potentially decreasing the occurrence rate of giant cell arteritis. I lecture on that with Dr. Tracy Offerdahl. I know Joe lectures on that. I think we all kind of know what it has been out there, but do you have any experience with that? Have you seen it?
No, not at all. Not yet. Not as much as, do I think it's going to be big? Yes. I think it's going to be big, to be honest with you. But I haven't seen it a ton here.
Perfect. Thank you. Please move. Yep. Please move on to the next one. Thank you.
All right. Let's look at number 4, everyone, just to throw this in here. Meningitis. It's still out there. Meningitis is still there. Obviously, we may not see it that much, but usually meningitis patients have this intense headache followed by a stiffness, this nuchal rigidity that prevents the passive flexion of the head or the chest. And then, as you can see here, the patient could look ill, and they may have neurological findings and so forth. But take a look at meningitis etiology: bacterial, viral, fungal, parasitic, right? The usual etiologies. They could have photophobia, optic nerve swelling, and they're going to do your MRI, lumbar puncture, and then they'll treat accordingly to the etiology. So pleocytosis is a definition of increase in white blood cells in the cerebrospinal fluid. Acute meningitis is hours to days. Chronic meningitis is 4 weeks or more. And then aseptic meningitis means no cerebrospinal fluid bacteria was found. Let's say an enterovirus is the cause and so forth. So this is just some differentials there, some definitions, some things we want to keep in mind. So you see here the swollen optic nerve. Okay, so you can see swollen optic nerve. The patient might have nuchal rigidity, things of that nature. This patient came into emergency and they said, my vision has been blurred for weeks. Now I'm getting this headache and I can't move my neck. And you see the dilation, the fields were constricted. We sent her to Penn. She was sent to Penn immediately, and she had optic nerve sheath fenestration surgery done that day. This was a viral meningitis. Okay. Other causes of meningitis: Lyme, syphilis, TB, listeria. Could be an amoeba, West Nile virus, and so forth. But meningitis is there. Obviously, any swollen optic nerve, you're going to get out. But the point is, it's not always pseudotumor cerebri. It's not always grade 4 malignant hypertension, right? It could be meningitis. And I just thought this was interesting. people are entitled to more than one disease, right? So this individual, this is still under the meningitis category. This person doesn't have meningitis. I just put this up here because this person has pseudotumor cerebri and diabetic papillopathy. Hay-Ray feels that diabetic papillopathy is not the right term. Hay-Ray feels it should be called a non-arteritic anterior ischemic optic neuropathy. That's up to you. But I just put this up here to remind the group that people are entitled to more than one disease, right? They could have meningitis and they could have something else going on. So every swollen nerve doesn't have to be one diagnosis. It could be multiple. And if you look here, look at the causes of an optic nerve that might not have very nice margins. Optic neuritis, AION, AAION. We showed you the cat scratch earlier. Anomalous nerve we didn't talk about, and then the swelling of the optic nerve, papilledema from increased intracranial pressure. So now we're at the next true emergency. And I'll go through this. Guys, I told you I'm at my Elkins Park campus. They lock us down at 9 o'clock. So I promise you, I have to be out of here by 9 because I don't feel like sleeping in here tonight. Okay, so I'll be done by, I'll follow COPE and I'll be done by 1:45. But if you look here, this is the next emergency, obviously. You see this patient is a 16-year-old male with a brain tumor. Look at the swollen optic nerves. It's a left temporal lobe astrocytoma. Okay, and you can see that very clearly. Asymptomatic, 20/20, 20/25 vision. You can see the tumor here. You can see what it's done to the lateral ventricle. You can see what it's done to the other. You see how the large tumor is here, here, and here. And you've heard this before. You see the midbrain? They call it Mickey Mouse midbrain. Just looks like Mickey Mouse. And you know what goes through Mickey Mouse's ears. Those are the crus cerebri. So your corticospinal tract that moves your arms and your legs, those go through the crus cerebri, Mickey's ears. Pretty soon, if this tumor would have grown more, you can see Mickey's ear here is the crus cerebri is crushed. That corticospinal tract is across, that corticospinal tract that goes through the crus cerebri is a cross system. He would have started to have, this patient would have started to have motor and sensory deficits. So swollen optic nerves. This one is not a tumor. It's this one, Dr. Perno had me look at this. She's a peds doctor, but 16-year-old, 317 pounds and a BMI of 52. What Dr. Perno was really scared about was the amount of blood that went with this. This ended up, they did everything, MRI, MRV. This ended up being pseudotumor cerebri. There was no tumor, but it's still an emergency, obviously. And once again, take a look here, everyone. We all know this. Pseudotumor cerebri, idiopathic intracranial hypertension, diagnosis of exclusion to an extent. And then all of these other things have to be ruled out. We just talked about meningitis. We didn't talk about Chiari malformation and so forth, but I'll show you a few things here that are coming up. But here is the young boy that had this. I want to show you this. This young boy here, let's say astrocytoma. Here's, let's go back to the brain tumors. Astrocytomas comprise 80% of all central nervous system tumors. Pilocytic astrocytomas tend to be younger, teenage years and so forth. Fibrillary is about 25 years or older. Anaplastic is a little bit 25 to 50, let's say. And then we all know about glioblastoma multiforme, right? The most aggressive of the brain tumors that are astrocytes as the etiology. So that young boy, I can't remember if his was pilocytic or fibrillary, this young boy here, but it was an astrocytoma. All right, so swollen nerve. And then I want to show you one other thing, everyone, as an emergency. You see this glioblastoma multiforme? Look at this case that I had. This man came in as a routine exam saying something is not right with my vision. When you dilate him, there is an afferent pupillary defect, a small one. When you dilate him, he has the classic optic tract. You know how you got optic nerve, chiasm, tract to the lateral geniculate body of thalamus. He has a classic tract lesion. And what do I mean by that? One side has the bow tie atrophy, the other one has the temporal atrophy. He has what's called a right homonymous hemianopsia, denser above than below. Everything fit the bill. We knew something was basically in the left tract area. And if you look carefully here, you see he has a large glioblastoma multiforme of the temporal lobe, the entire temporal lobe. And here it is again. Here it is again. And you see Mickey Mouse. So you know you're at the midbrain. And you can see Mickey Mouse's ears or the crus cerebri where the corticospinals, corticobulbars go through. And this tumor is compressing Mickey's ears. So he would have lost sensory and motor shortly as well. So my point to all of you is that it doesn't have to be a swollen optic nerve. You all know this, I'm just reiterating it. It doesn't have to be a swollen optic nerve to be a tumor. It could be a specific type of pallor or general pallor, okay? You can see the tumor there. You can see the tumor here, okay, on different cuts. All right, brain tumor suspicion, everyone, just quickly here. If you look here, for patients with primary or metastatic brain tumors that have a headache at the time of diagnosis is about 30%. Brain tumors, do they have pain, nausea, vomiting? About 20%. Headache, eventually 70%. Most brain tumors, everyone, not most, some will give you a seizure early, right? They'll give you a seizure. And here's your typical pseudotumor cerebri. Swollen optic nerves, there's some hemorrhaging, but is this a brain tumor? So forth. So that's why the MRI is done. And I wanted to show you one other thing here. You see this MRV? You know, this is interesting, the magnetic resonance venography. They're always looking at the MRV as well. You see, because the superior sagittal sinus could be blocked. And what this was a swollen optic nerve in each eye, but it was from a venous sinus thrombosis. The superior sagittal sinus is going to drain the blood of the cerebrum, right, cerebral hemispheres, a lot of it, along with the cerebrospinal fluid. And if it's blocked by a thrombus or something else, that's why if you go back, they're going to get an MRI, rule out the lesion, they're going to get an MRV, and so forth. But what happened in this, what could happen if this is misread, sometimes having a venous sinus thrombosis and being on Diamox is not the best thing. Right? That combination may not be the best. So if it's read wrong, if this MRV is read wrong or something is read wrong, you can have a problem. But this is venous sinus thrombosis, the superior sagittal sinus in this case. All right, real quick, let's finish up here. Let's move on to the next emergency, open globe. Now I want to show you something here. Here's the categories that we stress here big time. If a person has a traumatic event, you see this here, the rupture? The ruptured globe is from a blunt object, blunt. Tennis ball, a fist, basketball, football. Penetrating injury, sharp, through one eye wall. Perforating in one eye wall, out another. You see intraocular foreign body? I don't know why it has its own category. It's really penetrating. And then there could be mixed. So open globe injuries are not good. So injuries are bimodal distribution. Young men, older individuals. Young men because of the prefrontal cortex and alcohol. Older people because they trip. Men are 3 to 5 times more frequently than women to have vision-threatening eye injuries. And recurrent disease is ocular trauma. How many times have you seen a mechanic come in? Or they don't wear protective eyewear over and over again. What we stress here are the zones. The cornea is zone 1, 5 millimeters out is zone 2, and then anything beyond that is zone 3. Those are the zones of injury. Anytime you have, remember the 3 weakest parts of the globe, everyone, the limbus, the insertion of the recti muscles, and the insertion of the optic nerve, if it's really an insertion. Those are the 3 weakest parts of the globe. Anytime you have this amount of subconjunctival hemorrhage like this at the limbus, it's always an open globe until proven otherwise, right? Remember, that's very important. Look at this person playing basketball. If you look at me, I don't know if you can see me, he takes an elbow, let's say coming from outward towards inward, temporally towards nasally. plays the basketball game, then he starts to notice he sees red. If you look at his posterior pole photograph, you see this line of blood. You follow the blood back and you get this thing. Well, what is this thing? When you have the patient, let's say, move up and straight, this big white thing moves. It's got an opening here. This is a penetrating injury. That big white thing, everyone, is his lacrimal or ethmoid bone that fractured and went into his eye. Here is the opening right here. This is a penetrating injury from behind, from his own orbital bone. Okay. And then look at this person, same patient, foreign body, went right through the cornea. That night he's in surgery, the next day he's in surgery so that he doesn't have an endophthalmitis form. And then the other eye could get sympathetic ophthalmia. So penetrating injuries are not good. And look at this one. Here's the endophthalmitis forming already. The blood vessels are turning white, endophthalmitis. So the interesting thing here is the incidence of endophthalmitis following a penetrating injury is between 5 and 14%. And bacillus and staph are the most prevalent. So you got to be very careful with that. But once again, open globe injuries. And these are closed globe. We see these all the time, closed globe injuries. Here's a choroidal rupture from trauma. Got to look for that choroidal neovascularization membrane rest of their life for the most part. And look at this one here. This is a fresh one. This kid came in. I saw him. I'll tell you why. He's a Caucasian patient. See the choroidal rupture here? So look at all the commotio-retinae. Commotio-retinae is outside or outer, not outside, but outer edema of the photoreceptors. The reason I told you he was Caucasian, he's 15 years old. He was working at a banquet hall. And at night, he decided to walk home, like late at night, and a gang caught up to him. And they beat him up pretty severely. But I never saw anything like this. And let me rephrase it. They were kicking him so hard, he had an imprint of a lug shoe on his face. That's how they were just stomping on him. And what happened was he has the choroidal rupture. All of this is Berlin's edema, or let's say just say commotio-retinae, outer retinal edema. But he has a huge dialysis, a tear at the ora serrata that needed to be fixed. But it's not an open globe. These are open globe. All of these are open globes. And that's the true emergency. All right, let's finalize here. We're almost done. I have a large HIV population here. These are interesting. 80% of patients with HIV will have an ocular problem. The majority of those 80% are dry eye because the virus will infiltrate the meibomian glands, the lacrimal glands, and so forth. But see this patient here? He denies HIV and he denies an organ transplant. But this particular patient here had severely reduced vision. You can see there's vitreal cells. You know, everyone, it's kind of interesting. I'm just throwing this out here. I think you'll find this pretty cool. There's no such thing as a vitritis. There's no such thing as a vitritis. What I mean by that, it's a play on words. I don't call it, hey, I have an aqueitis. What did you find today, Dr. Polino? I found an aqueitis. You don't say that. You say I have an iritis, or you say I have a uveitis. There's no such thing as a vitritis. You either have, the vitreous isn't inflamed. You either have a retinitis, or you have a phlebitis, or you have an arteritis, or you have a choroiditis to some extent. It's just a misnomer, but it's just kind of fun to say that because if you really kind of think about it, it's true. The vitreous isn't inflamed. It's one of those other problems. Here, it's the retina. You got a retinitis that's giving you the vitreal cells. But what happened here, this man kept saying over and over to me, intermittently, he kept saying, Dr. Polino, when I go home and I go to bed, the rats, they attack me and they eat my scalp. So after him saying it 5 times, you got to look. And the scalp looked fine. But once we dilated and saw this cheese and ketchup, it's cytomegalo. So we sent him that day to Wills and also Jefferson. Jefferson Medical School is Wills. He didn't go to either appointment. He went to Jefferson to get tested, and Wills for the eye, he just didn't go and wouldn't go. So more than likely, this is HIV, cytomegalovirus. Remember, to get cytomegalovirus, your CD4 count has to be usually lower than 50, and anything below 200 is HIV/, Anything below 200 is AIDS. You have a CD4 count below 200. All right, HIV in general, 34 to 35 million people worldwide. In North America, about 1.5 million. In the United States, about 1 million people with HIV. You got the initial stage, the chronic stage, and the final crisis stage. And what's really interesting here is that until heart therapy came out, we used to see a lot of HIV retinitis here, specifically cytomegalo. And then you remember heart, highly active antiretroviral therapy. That's really calmed things down. But in case someone doesn't know they have HIV or doesn't want to get tested, you can still see there are two forms of cytomegalovirus. We all have cytomegalovirus, mainly in our mouth. It's a form of a herpes virus. But when the CD4 count goes below 200, you got the HIVs turning into AIDS. And then when you get close to 50 CD4 count, this could come out. But look at the one on the right. Whenever you tend to get cytomegalovirus patients, 25%, 1 out of 4 will get a retinal detachment. And then there's another form of virus called BARN, or ARN, acute retinal necrosis, and that's an even higher risk of RD. It's about 40 to 50%. All right, last emergency, and I'll tell you why this is an emergency, then we're done. This is a really interesting case. I don't know how this happened. This came in as, I was working with a surgeon that day, and this is a lawyer, a 29-year-old lawyer, female lawyer, and she said, oh, I'm here because they think I have an RD. They think I have an RD, which is fine. And I said, oh, did they see you today? No, they think I had an RD, but I was seen 14 days ago by someone on the outside. So I was a little concerned when I saw her. And you see here, I want to show you this. We all know this, and I'm just going over this with you. I apologize. You see this picture on the left? This picture is of the posterior pole. This is the macula, everyone. This is the macula. The macula is 5.5 millimeters. The fovea is this. This is the fovea, 1.5 millimeters, 1.8 millimeters. The fovea is the same size as the optic nerve. The fovea is part of the macula. So when the surgeon saw this, the surgeon wants to know, is the macula off or is the fovea off? It's big to them, very big to them. And the reason for this, I was with the surgeon, as I told you that day. This came in at 5 o'clock at night. And by 9 o'clock, he asked me to go with him. We were in surgery. All I could do, obviously, is observe. So I said, why are you so concerned? Their biggest concern is they don't want that fovea off, especially if it goes through. They don't want foveal fixation. If this thing splits fixation, it's a big problem. So when the fovea is off, if this whole thing was off, he probably would have gone, or she probably would have gone in the next day or a few days after that. But because this was so close to the fovea, this became an emergency that night. And that's how a lot of people still approach it. I can't say every retina specialist will do that, but a lot of them still do. They do not want this to split fixation. So they don't want to wait, okay? And
hey, Carlo, can you go back to that picture?
yes.
Because I think that is extremely, extremely important to echo, especially if you have retinal detachments come in. I think another way you could say this is a macula off, fovea on retinal detachment.
That is correct.
Right. And I think a lot of the colleagues, out there forget that macula is, 2 disc diameters. I think you said 5.5 millimeters. And that inferior macula is detached.
That's correct.
Inferior macula. So macula off, fovea on, that patient will be in the ER or in the OR. So.
Yeah, correct. That's right. Yeah. Yeah. And so it's kind of interesting. Sometimes I'm saying this in a very kind way, but sometimes a lot of doctors just interpret everything as macular fovea, and that's not necessarily true. And I think that's why it's important to kind of keep in mind, like we all know this as an optometrist, but the fovea subtends, maybe 20, 15 degrees at the most, but the macula subtends a lot more, 30, 35, it's big. They're separate, even though fovea is part of it. So I just wanted to show you this. We all know about the flashes and the floaters, but what I wanted to show you, take a look at this, everyone. If you want to protect yourself from a court of law, when you when you look at your periphery should be no breaks, no detachment, if you want to look at it from a court of law standpoint. And what's a break? A break is a hole, a tear, or a tear at the ora serrata, a dialysis. So if you write no break, no detachment, that break is a very encompassing term. And you see here, this dialysis is a tear at the ora. This is a horseshoe tear. There are different types of tears, mostly caused from PVD/trauma. They lead to this large type of detachment rhegmatogenous, which means break. So here is the lawyer that I just showed you. Here's the lawyer right here. This is her. Here's her this OCT, the older OCT, but this is her. You can see the fovea is ready to come off. Here's the detachment. Here's the B scan, let's say right here. There's a B scan of an RD. And then please remember, everyone, I'm amazed. I don't know, even our students, and sometimes I don't know why they don't look at the vitreous clearly. But you see the posterior hyaloid of the vitreous. The vitreous is one of the biggest structures of the eye, and it's overlooked. Let me look at the lens and then jump right to the retina. It doesn't always make sense, but what I wanted to show you, look at these things. This is what is called an anomalous PVD. Anomalous. It is liquefying, that's called synchesis, at a much faster rate than it's pulling away. That's called syneresis. Synchesis is faster than syneresis. And if you follow this, you see the posterior hyaloid, but if you follow it closely, it's not a complete PVD. This is what's called an anomalous PVD. If it happens to be over the fovea and it can't pull away, you're going to get a macular hole. If the anomalous PVD is up in the periphery, close to a lattice lesion or cystic retinal tuft, the anomalous PVD will cause, when it eventually pulls off, a tear, and you'll get this. So I just want to reiterate, we have to look at this vitreous a lot better. Remember, synchesis is liquefaction. Syneresis is pulling away from the internal limiting membrane. In a good PVD, a normal PVD, syneresis equals synchesis. That's what that is. If it doesn't, you get anomalous PVD that you see right there. And finally, everyone, how are these fixed? Mainly now, the buckles used to be used. They're getting away from buckles, but now they like to do the vitrectomy if they can, gas bubble, silicone oil. And you can see here, everyone, if that can't be used, well, there's the silicone oil. Pneumatic retinopexy means I'm going to fix it with a laser or CRAO without doing a vitrectomy. That's a retinopexy. Not as much success as the vitrectomy with the treatments. And there's your 3-port pars plana vitrectomy. It takes about an hour, a little over an hour to fix. Okay. And there's your buckle that's really not used as much anymore, but they're still using them in some cases. So, okay, I hope I finished on time. I know at the end there, we might have gone a little bit faster than normal, but a lot of those are your emergencies. And I guess I have 2 minutes or so, 4 minutes or so to take some questions, and then I'll be happy to, answer them on cpolino@salus.edu if you think of them later. But we had a pretty good attendance tonight. I see about 110 people, so that's wonderful. 109 people. So good.
No, we had a very good attendance tonight. I just want to go back to something you had said about what you record for retina to keep you out of trouble medical legally. I've done probably over 100 cases, and probably 20 of them had to do with retinal detachments, and it's even more fundamental than that, Carlo. What people need to write, when you're dealing with flashes, floaters, is that you dilated. What did you dilate with, and what did you look with? Too many times I have to go back and ask an attorney what happened. When I say this, when I do this, I write down everything that I do and all the pertinent negatives. No pigment, no hemorrhage. Examine upright and recline, scleral depression, 20/90. These are all things that make a very, very big medical legal difference.
Yeah, it's huge. That's exactly right. All of that stuff has to be in there. That's correct. And it's so important. And sometimes I wonder, like, it's not a big deal, but when the student writes no breaks, no holes, you know that they don't know what they're talking about, because a break is a hole. But you're right, everything has to be in there, and it's really good. And I couldn't stress that more. So dilate, dilate, dilate. And hopefully today we gave you as much, I gave you as much clinical relevance as needed, and hope you can use it in clinic. So fire away if you have any. How long do you want me to stay on for, guys?
Let me do the this wrapping up here. Carla, you can hop off as soon as I get into the housekeeping, but I quickly went to our website and put on our philosophy of optometric education consultants, and it's basically to enhance patient care through timely, clinical, pertinent, and highly interactive education. Now, we cannot be too interactive here in a webinar, but also assembling top clinical educators to deliver high quality COPE approved clinical education in a relaxed environment. And you certainly helped us with our philosophy of optometric education consultants by delivering your identifying true ocular emergencies of the posterior pole. So you're getting a bunch of kudos here in the chat box. You're getting your virtual round of applause that's out there. So thank you.
All right, guys. Joe, Greg, Vanessa, thank you very much. Everyone stay safe, and hopefully we'll all chat soon. But thank you for the opportunity, everyone. It was my pleasure. And have a good week ahead. And if I don't see you, have a good summer, everyone.
Yeah, thank you for doing this, Carl.
Yeah.
It was terrific.
Yeah, thank you. Thanks, guys. Talk to you later.
All right, thank you.
Bye-bye.
Bye-bye. Get out so you don't get locked in, have to stay there tonight. So.
Yeah. Greg, what do I have to do here, buddy? Just stop sharing?
You're good. I already got you off. You're good. So
okay, good. See you guys.
just log off. All right, take care.
Bye-bye.